Bismillahirrahmanirrahim. Check, check. Bismillahirrahmanirrahim. I'm Dr. Osama Chima, trainee registrar in Department of ENT, Sheikh Zayed Hospital, Lahore. I welcome you all to the PSORL meeting, monthly meeting, which is held at Sheikh Zayed today. And I welcome all the guest of honors. We will be introducing them later. And first of all, I would like to begin our meeting today with the recitation of Holy Quran. For that, I would like to invite Dr. Arsalan.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم قل أعوذ برب الناس مالك الناس إله الناس من شر الوسواس الخناس الذي يوسوس في صدور الناس من الجنة والناس.
Now, I would like to invite Dr. Ali Shian, who is a trainee registrar in our department. He will be presenting the first case today.
Assalamu alaikum, everyone. I welcome you all to the PSORL meeting today, hosted by Sheikh Zayed Hospital, the ENT department, under the kind supervision of Associate Professor Dr. Sarfraz Latif. The topic of my case is endoscopic CSF repair in a 2-year-old child. It is a challenging task, but it is achievable. I'll start with my case presentation. A 2-year-old female child presented with left-sided nasal discharge for 3 months. She also had a history of fall and head trauma 3 months ago. The characteristics of nasal discharge was that it was unilateral, it was continuous, watery in consistency, whitish in color without any smell. It was aggravated with bending forward, and there were also occasional spontaneous gushing of fluid as well. There was no nasal blockage, sneezing, epistaxis, any other eye, ear, or throat symptoms. When it came to evaluation, the child was highly non cooperative and there was limited examination. So we went for radiological evaluation instead. A CT scan, nose, and paranasal sinuses was carried out, in which a defect was seen in the lateral view at the region of ethmoid plate. As you can see here, marked using an arrow, there is a bony defect seen. MRI nose and paranasal sinuses was also done, and it also showed a defect at the level of ethmoid plate with the CSF leaking inside the ethmoids and the nose. So a diagnosis based on the history and on the radiology was made that it is a case of CSF rhinorrhea, as conservative management was already carried out for 2 months. So plan was made to surgically repair the defect using endoscopic technique. A pre-op assessment was carried out that involved routine investigations. However, intraoperative use of fluorescein dye was avoided to mitigate the risk of anaphylaxis and adverse reactions, as it is less commonly used in children. However, the FDA approved dosage for children is 7.5 milligram per kg to 20 milligram per kg with a maximum of 500 mg. Now, the endoscopic technique for this disease, here you can see the CSF leak. The CSF is leaking from this ethmoid region, and it can be appreciated as a form of liquid. So in the first step, we have identified perioperatively that there is a leak. Here you can see that the bed has been prepared as well as a meningoencephalocele that can be appreciated coming out from the ethmoid region. Now this seal, the defect has been plugged using fascia lata as well as temporalis fascia taken from the patient himself. Here you can see that a Haddad flap has been raised from the nasoseptal region. It has been rotated and it is being taken up to our defect. And by repairing the defect using this flap is a very good technique as it provides a well vascularized tissue for the defect to heal. Here you can see that layer of sponge stone has been placed to ensure good hemostasis. And here a splint has been placed at the defect to provide extra support as well as avoid any adhesions in the nose. Now, for the literature view, CSF leak, let's start with the etiology. It is mostly traumatic, 80 to 90%, and that trauma can be due to a head injury, that is almost 60% of the cases, or iatrogenic, for example, during endoscopic sinus surgery or skull-base surgery or transsphenoid pituitary surgery. That accounts for almost 20% of the CSF leak. The second type is a spontaneous leaks. These can be secondary to raised intracranial pressure, which is up to 45% of the cases, as well as leaks with normal intracranial pressure, which are up to 55% of the cases. Congenital diseases such as meningocele and cephalocele can also cause CSF leak, but they are less than 5% of the total cases. Now, the common locations of the leak. The most common location is the ethmoid roof. The most of the leaks are along the course of anterior ethmoid artery. Secondly, we have cribriform plate. Then there is sphenoid sinus, in which mostly spontaneous CSF leaks occur, and the frontal sinus leaks are very rare. This is a diagram that is showing that the most commonly encountered areas for leak are the olfactory fossa or the cribriform plate. In the iatrogenic CSF leak, the area of fovea ethmoidalis or the ethmoid plate is the most common cause of leak. Here we can see a leak most commonly. However, in spontaneous leak cases, it is usually the area of sphenoid sinus that shows that there is a leak. To diagnose this disease, an estimation of glucose using glucose test strips can be done. The glucose concentration of more than 30 milligram per deciliter highlights presence of CSF. However, this test lacks specificity and sensitivity. A newer modality, beta-2 transferrin, is the gold standard for diagnosing CSF. It has a sensitivity of 94% to 100% and a specificity that is also close to 100%. In the radiological approach, we have a primary and then we have some secondary investigations as well. In the primary investigation, CT scan is our first approach. A coronal CT image could demonstrate fractures and bone defects. However, the limitations of CT are that the fluid is seen poorly and we may not be able to identify exact site of leak when there are multiple fractures or dehiscence. MRI has an advantage that it can show us defects in the cribriform plate and herniation of meninges and brain tissue. And it is usually combined with intrathecal contrast as well. The secondary investigation for diagnosing this disease includes CT cysternography, radionuclide cysternography, and fluorescence cysternography. These are not routinely done, but are also an additional modality. Now, to manage this disease, the first approach is conservative management, and most of the traumatic CSF rhinorrhea can be managed. The routine management involves the use of acetazolamide, laxative, prophylactic antibiotics. Measures such as bed rest, head elevation, avoidance of sneezing are also effective. When it comes to surgical repair, we have the traditional approach, which is extracranial repair. It has a success rate of 60%. However, there is significant morbidity and mortality associated with it. It also leads to formation of scars on the face. Then we have the intracranial repair, which has a bit of a better result than extracranial, a success rate of 80 to 90%. However, the intracranial approach requires us to perform craniotomies depending upon the site of leak, which is also a very tedious and complications causing event. Nowadays, intracranial repair is only employed when endoscopic repair is difficult, when the defect is more than 5 centimeter, or there are multiple defects at different areas, or in the case that there is a frontal sinus leak, which is difficult to be managed by endoscopic repair. Endoscopic repair, when possible, is an excellent result and has up to 100% success rate. It is the gold standard approach. In this approach, olfaction is almost always preserved. And as you can see here, multiple authors have reported a success rate of more than 90% and 100% as well. And even at second attempt, the success rate went near 100%. Now, to start with the challenges in pediatric endoscopic repair, specifically to the pediatric population, I would invite Dr. Sarfraz Latif to further guide you.
Thank you very much, Doctor. So I will not guide you, but I am sharing my experience. So I am sure you are all doing the endoscopic CSF repair, and the youngest child which I operated few months back was 4 years, and this case was unique because the age was 2 years. So it was new for me. So initially I was reluctant to operate because I'm not too much familiar with the pediatric sinus anatomy. So next. Because the child was not cooperative. We have done the two consultations pre-operatively. In both consultations, the child was outside the consultation room. So because the child was so frightened with the injections and with the multiple consultation with other doctors that even when entered the room, then the children start crying. So avoid further staining. I have not examined this child pre-operatively. Next. Yes, radiological investigations are also difficult because uh, all both CT and MRI was done under general anesthesia. Next. So it was done under general anesthesia.
Continue, Kadam.
Yes, yes. So the other problem was the size of the nostril because I was afraid that maybe I was unable to approach the ethmoid sinus because simultaneously I have 4 mm scope. And when you pass the scope in the nasal cavity, then there must be the space for the other instruments also. And I will show you the some videos in which sometimes we have to use three instruments, one scope, other grasping instrument, and some handling instrument like prayer. Next. Mhm.
जी सर।
Right, right. Next, I was talking about the instruments. So I have very limited endoscopic nasal instruments. So for this case, I choose all the ear instruments. So these are the prayer, elevators, needles, picks, and so we selected these instruments for the repair. Next, I was talking about the exposure. The size of the nostril was small, but simultaneously, but with my experience, I have noted that when you are in the nasal cavity and when you approach the ethmoid sinus, there is an appropriate space for working. So I have not faced any difficulty in exposing the defect, preparing the bed, and closing the defect appropriately. Next. So the other important thing which I will share with my colleagues that Haddad flap is a brilliant flap. So when if the defect is large in the redo cases or in some difficult situations when you are not sure that you have sealed the defect, so I always use the Haddad flap. So it is a brilliant flap. You can increase the size of flap as you can, and you can rotate at 360-degree in whole the nasal cavity according to your the need and the demand. So Haddad flap is a very good flap. So in difficult situation, we must be expert and we will be able to raise the flap, and this is a very good flap, especially for the CSF closure. The other important thing which I will like to share with you that with the passage of time, we have learned that when we make the chemistry of sealing the defect, we put the pack initially, but when we remove the pack, and there is some disturbance of the our chemistry of that sealing uh, pack material. So we know we are using the splint. We make it an arc shape, and we push this arc splint at the roof, and then we use the Marisol dressing in the arc splint, and that push the all our packing material to the skull base. So we have not faced any difficulty, and my message to our junior surgeons, and I'm sharing our experience with the closure of the pediatric CSF repair, that the steps are the similar steps. So if you found the results are very good, and the post-operatively the recovery was uneventful, and we discharged the patient in after 2 days, and after the 10th day we removed the nasal dressing at this point. The baby is doing well, and in second anesthesia, sir. Yeah, yeah, second anesthesia. So any question, so I will share my experience with CSF. So no, we will present our सर लाइट ऑन करेंगे, थोड़ी नजर नहीं आ रहा सर. It was a nice presentation. Very nice. But being a student, there are certain things that you do. Did you go for sugar in the sea, any fluid that was coming out, and what is the level of that? Actually, sir, there was the fluid ever collected and sent to the laboratory for chemical? No, sir, we have not tried to identify. Beta transferrin is not available. Yeah. Easily, so that was also part. It yes. Was your conviction on clinical grounds. Yes, sir. Yes, sir. Because there was a history of trauma. This is good enough. Right. Because you are the clinician, have been in time and space, whatever is available. This is what I, the postgraduates have to learn. At times you have to make decisions when everything is not up to the mark or understand. My next question is, what was the position of the patient while
MRI was.
Sir, we do the MRI in CSF protocol position. In that was the prone position because we they do the MRI in spine position, but we take some slices in the prone position.
At the display of that MRI, the
लगाना सर
what we usually see is herniation of the brain
MRI.
in the MRI in prone position.
Right.
The in continuity in the T2 waiting, we see the fluid coming out of the fluid goes to continuity. Okay, bone cannot be seen, bone defect cannot be seen. We appreciated the herniation of the brain, the continuity of CSF. Was that appreciated in this patient? I can see the CSF leak, some like in continuity to have a very thin C and very. Did they report it like that? They feel that there is a CSF.
Sir, actually ये जो MRI this is without contrast. तो जब हम prone position में करते हैं तो MRI is collected in the nasal cavity or somewhere in space. तो अगर हम इसमें देखें ये इस position में शियान ने लिया नहीं है लेकिन prone position पे हमारे पास इसके slices थे.
इसमें herniation of the brain is not being appreciated. This is what we want to.
Yes.
Want postgraduates that we are looking for the herniation. So very nice presentation.
Thank you, sir.
And I appreciate. Thank you.
So any yes. Yes. Because जी क्योंकि उसके बगैर तो पॉसिबल ही नहीं है तो इसके हमने बोथ सीटी भी करवाया था और एमआरआई भी करवाया मेरा ख्याल ये क्योंकि एमआरआई की डिमांड होती है कि पेशेंट हिले ना हाँ मेरा ख्याल है नहीं चूंकि इसमें डिमांड होती है कि पेशेंट का सर ना हिले तो मेरा ख्याल ये जीए इज ए सेफ और दूसरे नंबर टाइम टेकन भी है आधा पौना घंटा लग जाता है हम्म,
My question like post operative we normally provide are there to avoid any but in the case it's not possible or seems so we need some like or something like or we need to put some tags in to get the extra support.
no. डॉक्टर शाहिद इसमें हमने सिर्फ एज पर रूटीन जो कि हम सीएसएफ रिपेयर के बाद बैरिस्टल ड्रेसें रखते हैं वही रखी थी लेकिन ऑब्वियसली क्राइंग या वीपिंग बच्चे के लिए तो अनअवॉइडेबल होता है उसमें कोई स्पेसिफिक है नहीं और हमने कोई ऐसे स्पेसिफिक एडवाइस की भी नहीं और सेकेंडली शयान ने बताया कि हमने इसको फेशियल आटा लगाया था नॉट टेम्पोरल फेशियल हाँ जी हमने सिर्फ फेशियल आटा लगाया था टेम्पोरल फेशियल लगाया था तो उसने दोनों बता दिए हाँ जी सर खुर्शीद साहब
Just, I mean, there are people who still use those in the road. And I mean, I'm just saying it for the postgraduates. Right? You can confirm it on the CT scan and MRI. You know the location. But sometimes there are some hidden places as well, like sphenoid area, where you cannot even detect the CSF leakage. So fluorescein, if you see fluorescein coming out from there, so just for the sake of discussion, I'm saying that fluorescein still a choice should be kept in mind.
Okay. सर मेरा ख्याल अगर इफ यू आर श्योर अबाउट द इस केस में क्योंकि हमने इसको बहुत सीटी और एमआरए पे हमने बड़ा एवेलुएट किया था तो इसलिए आई वाज बेटर इलेक्टेड on the fluorescent dose and LP. हाँ, हाँ, हाँ.
I'm just saying for the postgrad,
Yes, sir.
that for exams and for these things, okay, we can use those for TKT.
Right,
Because
sir.
you were sure
Yes,
sure
sir.
very I was in your shoes. I was in your shoes. I would have done the
Right.
same. That's one thing just for postgraduate, I'm saying that you should keep in mind that no dose like 0.1 ml, 20% fluorescein,
Right, sir.
0.1 ml per kg.
Right, sir.
You use 20% of fluorescein. It's supposed to be very safe. No side effects have been shown so far. I mean, nothing reported there.
Right, sir.
वेरी नाइस प्रेजेंटेशन। एक तो वैसे ये बड़ा रेयर केस लगता है क्योंकि बच्चों में हिस्ट्री ऑफ फॉल तो अक्सर होती रहती है।
Yes, sir.
लेकिन उसमें इस लेवल की फ्रैक्चर का हो जाना, दिस इज नॉट अ कॉमन थिंग।
Yes, sir.
And that also did not heal spontaneously।
Yes, sir.
मतलब थोड़ी बहुत लीकेज हो जाती तो, लेकिन ये यूनिक केस है। ज्यादा जब आपके पास भी आया तो आप बता रहे हैं कि बहुत ज्यादा
Yes, sir.
फ्लश करता था उसमें। So definitely pediatric repair not only this repair, even all procedures in the nose,
Yes, sir.
and even in the ear of children are difficult, and the reasons are multiple, especially the space available because of that is anything that might have ruptured because all already बिल्कुल ये भी एक पॉसिबिलिटी हो सकती है कि बच्चे के स्कल बेस में ये ऑलरेडी एक डिफेक्ट या और फॉल से वो रप्चर और उसके बाद लीकेज का वो सारा सिलसिला बन गया। तो बहरहाल वेरी नाइसली मैनेज। तो कितनी देर तक आप कंसर्न रहते हैं आफ्टर रिपेयर? नो इट इज
Heat.
heat.
Sir, once we remove the nasal dressing or nasal pack and remove the nasal stent, then we had the second look under anesthesia after the 10th day when I removed the nasal dressing. So that flap gives you a very good look of complete healing of the roof of the nose, or you can say the whole agribiform plate is covered with a nice healed fascia. So the complaint is also resolved. So that's the clinical clue that the defect is closed. Sir. Yes, sir. Sorry? Sir, you are absolutely right because this is the complication with dark flap. Because you cover whole the olfactory area. Obviously, smell will be disturbed on one side. So that is the concern, but the other side will be used. लेकिन सर चूंकि फ्लैप को लगाते तो olfactory एरिया पे वो छत पे चला जाएगा।
Fibers of the roof of the ethmoid. I think most of the fibers are medial to the middle terminus. I mean, the middle terminus can be removed and they cover the whole cell itself.
तो olfactory एरिया को कवर कर लेगा तो इसमें डिस्टर्ब तो होगा फिर।
The child should be protected so that there is no fracture on the other side.
सबसे वो बच्चा उनकी गोद में ही है।
I appreciate Dr. Safrali
And you've done well. But this tells us some efficiencies that you have in our specialty. You have done it. You are brave enough to take it up. ऐसे बच्चों में
otolaryngologist जैसे आप अडल्ट में हैं, ये challenge लेना can go both way, this way or that way. So this points towards a gap in our specialty. This should have been done by an experienced pediatric otolaryngologist.
which is not existing at that time. And that takes her to a point again, ponder and think that we are far, far back from the other countries. So we all need to work on it कि हम pediatric otolaryngology जो है उसकी ट्रेनिंग उसके सेंटर्स एस्टेब्लिश करें एंड ये जो आपने सारा मैनेज किया है बच्चे को नसीजा भी दिया उधर ले गया या जो चीजें ट्रांसपोर्ट की वो सारी चीजें दैट शुड बी इन प्रॉपर यूनिट pediatric otolaryngology. दूसरा ये है कि थोड़ा सा मेरा कंसर्न ये है कि वो बोनी डिफेक्ट था हाउ लार्ज वाज इट कि फ्यूचर फॉलो अप के अंदर आर वी श्योर कि कितना उसका चांस हो सकता है कि वो जो हर्निएशन है ऊपर इंट्राक्रैनियल प्रेशर है इट माइट रीएस्टैब्लिश अगेन
काफी हम फ्रीक्वेंट
Yeah, लेकिन वो जितना भी डिफेक्ट हो बिकॉज
बोन तो नहीं लगाई
नो
ना
नो 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 नीड फॉर एनी बोन सर. मेरे पास एक पेशेंट आया उसकी फेस सर्जरी हुई और उसके वो ऐसी सर्जन ने ऑल मिड ट्रेपिजेट सारे खाए थे. उसका पूरा ब्रेन ही हर्निएट कर रहा था. अब उसमें ये डिफिकल्ट केस था मेरे लिए क्योंकि पेशेंट ने प्रेजेंट अजीब तरीके से किया. उसकी 20 days बैक हिस्ट्री हुई फिर उसके बाद फीवर हुआ और उससे पैराप्लेजिया हो गया मेनिंजाइटिस डेवलप हो गया. अब न्यूरो फिजिशियन ने उसकी मेनिंजाइटिस डील कर रहा था लेकिन उसने फिर कहा कि मेरी 20 दिन पहले मेरी नेजल सर्जरी भी हुई है. फिर उसने मुझे कॉल की तो उसके बाद उसको मैंने देखा तो मैंने तो जो प्री ऑपरेटिव स्कैन देखा और पोस्ट ऑपरेटिव स्कैन उसका ब्रेन का उन्होंने ऑब्वियसली किया था तो उसमें पूरी उसकी ऐसे हर्निएशन हुई हुई. मैंने कहा ये तो वो है. फिर उसने न्यूरो फिजिशियन ने उसका मेनिंजाइटिस ठीक किया और फिर उसको अपने डिफेक्ट किया. देखिए मेरे ख्याल कोई ऐसी अगर लार्ज डिफेक्ट है तो सेप्टल कार्टेज या कार्टेज आप सपोर्ट कर सकते हैं लेकिन हमें कभी ऐसी कोई डिफिकल्टी नहीं हुई. बट द साइज उसका वो बड़ा डिफेक्ट था. द साइज अबाउट 3 cm सेंटीमीटर इतना डिफेक्ट था. लेकिन उसको हमने हदायत लैब और यही प्लग इन किया सही हो गया.
That's very people like
Sir. Correct.
because the fat has got what's called stem cells.
Sir.
It has got growth factor. It has got many things. So fat is a beauty. I always use fat.
Right.
I always use fat and then cover it with the fascia or the fat.
That's what I use. So that's one option.
माशाल्लाह आपने वंडरफुल सही की है लेकिन कि अगर बिल्डिंग को सील भी आप सस्पेक्ट कर रहे हैं डिफेक्ट भी आपने बड़ा अच्छा एक्सपोज किया है तो डबल शेप फेट आपको अपने कंसीडर क्यों नहीं क्योंकि रेडिएशन के चांसेस बात नॉट
है कोई ऐसा प्रोलैप्स नहीं था.
Prolapse was very less. I
Prolapse
think
नहीं
it was
फेट
one.
आपको कंसीडर किया
जैसे मुझे लग रहा था कि ये स्ट्रेट फॉरवर्ड है तो सही एक्सपोज and I was expecting कि ये straight forward है.
Comes down, then you can bipolar it and then put the fat and plug it in. But this was very mild. So I think it was a mild case.
Actually, what is the chemistry of it? The first layer is the fat, and after that, the fascia lata temporal fascia underlay. Then we put the periplast.
आपने ग्रुप में भी ऑप्शन नहीं लिया
नहीं वो डाल
यू आर सो कॉन्फिडेंट
हाँ हाँ वो डालते हैं लेकिन थर्ड लेयर जब हमने हदात लैब संगे तो फिर उसके ऊपर that is called periplast or fibrin glue. I think there's the same thing. It's very expensive. It's costable 35 to 40,000. Next, next presentation is laryngeal aspergillosis. मैंने 4-5 मेरे कॉल्स हैं कि बड़े रेयर केसेस हैं आपके laryngeal aspergillosis.
ठीक है. I would now like to invite Dr. Sarmad Ilahi from LGH to present his case laryngeal aspergillosis.
Assalamu alaikum everyone. I'm Dr. Sheikh Sarmad Ilahi, working as a postgraduate resident in Department of ENT. Complaint of hoarseness of voice for the past 7 months. The patient was the patient had a third episode 2 months after the second episode, which did not settle by taking any medication, and hoarseness has persisted since then. The hoarseness has gradually increased and is now persistent for the past 7 months. There is no history of dysphagia, dyspnea, or vocal abuse, and no history of weight loss, cough, or rising temperatures. So in the medical history, the patient is a known hepatitis C positive case. There is no other significant past medical history. The past surgical history is also insignificant. In the personal history of the patient is a smoker and has been smoking 1 pack per day for the past 25 years. And since his complaint of hoarseness for the past 1 year, he has reduced it to 6 to 7 cigarettes per day. Insignificant. On general physical examination, a man of average height and build, sitting comfortably in bed, well oriented in time, place, and person, and vitally stable. On throat and oral cavity examination, there was poor oral hygiene and hyperemic posterior pharyngeal wall was midline, and gag reflex was positive, and laryngeal crepitus was also positive. We did an ideal examination and it showed an irregular growth on the right vocal cord. The right vocal cord movement also seemed sluggish. So to confirm our suspicion and to confirm our findings, we performed an FODL and it showed a right vocal cord whitish irregular growth along the entire length and it was extending up to the anterior commissure. You can see it in the picture, and this is a brief video of the FODL which we performed. As I've already told, you can see a white irregular growth along the entire length of the right vocal cord. So on neck examination, there were no palpable lymph nodes. Ear and nose examination were unremarkable, and the systemic examination was also normal. We ordered hematological investigations, which all came out to be normal. Chest X-ray was ordered, and it was discussed with the radiology department, and it too was normal. CT scan base of skull to root of neck showed a mass arising from right vocal cord. This is a picture of the X-ray, chest X-ray of the patient. As you can see, it is completely normal. This is a picture of the CT scan, and we can see a growth on the right vocal cord. So our differential diagnosis included malignancy, which we had a strong suspicion of, and then leukoplakia of vocal cord and aspergillosis. So we planned a direct laryngoscopy and biopsy to confirm our diagnosis, and the DL findings were similar to our FODL findings, which showed a a vocal cord whitish leukoplakic irregular growth along the entire length of right vocal cord. Representative biopsy was taken. When we were taking the biopsy, the mass was thick and fibrotic. The excised mass was then sent for histopathology. These are the before and after pictures of the surgery of the DL and biopsy which we did on the patient. And this is a brief video of the direct laryngoscopy and biopsy which we did. As you can see that we are taking a representative mass, and here you can see that we have taken a good enough chunk. So the histopathology report showed fragments of hyperplastic squamous with fungal hyphae, and aspergillus was favored morphologically. And Shaukat Khanum, the histopathology was done from Shaukat Khanum Hospital, and they recommended us a fungal culture for exact species identification. So we then ordered a fungal culture, and it confirmed our diagnosis to be Aspergillus fumigatus. So now the treatment plan, we sent a call to the infection control department of Mayo Hospital, Lahore. We also sent a call to pulmonology department of our hospital, LGH, to rule out pulmonary aspergillosis. Although the chest X-ray was normal and we were quite confident that there is a little possibility of any pulmonary aspergillosis, but still to confirm it, we had a call attended from the pulmonology department. Oral itraconazole 200 mg per day for 3 weeks was recommended by the infection control department of Mayo Hospital, Lahore, which we started. And now patient is on regular follow-ups. This is a video of 1 week after the patient has started oral itraconazole. As you can see, the patient is recovering well. Aspergillosis is most commonly seen as a secondary invasion from lungs and tracheobronchial tree in immunocompromised patients. Primary laryngeal aspergillosis is extremely rare, and only 50 cases have been reported worldwide in the past 10 years, of which half are primary laryngeal aspergillosis. Immunocompromised status like diabetes mellitus, cancer, AIDS, and tuberculosis, voice abuse, smoking, long-term antibiotics and systemic laryngeal radiation, intubation related microtrauma of vocal cord surface, exposure to large amounts of fungal spores. The patient usually presents with hoarse voice, shortness of breath, and oral itraconazole 200 mg for 3 weeks is the recommended treatment of choice, and majority of the cases respond well to the treatment. Treatment may be extended up to 2 months if response is inadequate, and IV amphotericin is recommended only for resistant cases unresponsive to itraconazole due to its high adverse effects. Long-term follow-up is recommended up to 2 years to check for any diseases. Thank you. जो दे देते हैं भाई जहाँ पे फंसेंगे वहां पे सर दे Thank you, sir.
Few things we need to remind
Yes, sir.
again and again, really, particularly for the postgraduate trainings. Uh, differential diagnosis में ख्याल ये है कि right
Yes, sir.
और बाकी जो aspergillosis निकल आया है मेरा ख्याल ज्यादा histopathologists का काम है.
Yes, sir. That wasn't our basically our DD initially. Yes, sir. नहीं था सर। जी सर।
हाँ हाँ वो अच्छा किया आपने।
खाना में
लेकिन पोस्ट ग्रेजुएट्स के लिए जो मैं बार बार रिमाइंड करता रहता हूँ, सर मैंने कराया था FODL से एग्जामिनेशन लाइन से स्टार्ट, एंड आई रिमाइंडेड कि इट शुड स्टार्ट फ्रॉम इनडायरेक्ट। इन्होंने आज बिल्कुल सही किया, आईडीएल से शुरू एंड फिर FODL के साथ आपको आई अप्रिशिएट। दूसरी बात यह है कि हिस्ट्री में अगर आप क्लिनिकल फीचर्स को आपस में मिक्स ना करें, सिम्टम और साइंस को लेना, जब आप बात करते हैं कि मरीज हिस्ट्री दे रहे हैं तो इट शुड बी टेकन एज फीवर। अगर आप टेम्परेचर से खुद थर्मामीटर से लेते हैं तो उसको हिस्ट्री ऑफ राइज ऑफ टेम्परेचर शुड बी देयर, क्योंकि वो मरीज तो थर्मामीटर से नहीं लेके आया ना, तो फीवर का बताएगा। तो ये सिम्टम्स में सिम्टम्स और क्लिनिकल साइंस, इनको जरा आप डिफरेंशिएट करें। और एक और बात जो ये है कि जो when we are dealing with the lesion here, या तो lesion की बात करें या mass की बात करें, when you talk of growth, right vocal cord की growth, that generally reminds you of what? Neoplasia. Benign neoplasia. तो उसमें एंड तक ये अगर उसको आप ग्रोथ को एक सिंपल लैंग्वेज में लेंगे, यू थिंक इन टर्म्स ऑफ न्यूप्लेसिया, तो एंड तक वो तो नहीं आई, वो तो स्पॉन्डिलोसिस। ठीक, सो वो टर्म्स जो बाद में एग्जामिनर आपसे डिस्कस करेगा और फिर उस पर आप क्वेश्चनिंग होगी, आपको लॉजिक्स देनी पड़ेगी, उनको थोड़ा सा इन चीजों को डिफरेंस। आई अप्रिशिएट। थैंक यू।
एक तो हमें जो ना आपसे गाइडेंस ये लेनी कि हमें हिस्ट्री के बेसिस पे कैसे जाना, एक फंगल इन्फेक्शन एस्परजिलोसिस मैलिग्नेंसी के पेशेंट्स से कैसे हम डिफरेंशिएट कर सकते हैं, आप उनका एक्सपीरियंस कैसे। दूसरा जो है मैंने जो अपना पर्सनल एक्सपीरियंस किया, जब हम बायोप्सी ले रहे थे, यूजुअली हम जब ट्यूमर की बायोप्सी लेते हैं तो फ्रेजाइल और ड्रीम जो है जाते हैं, तो यहाँ पे ये टफ फाइब्रोटिक जो है हम ये डिफरेंशिएशन। दूसरा हिस्ट्री में जो है ना बार बार ठीक होता है और लॉन्ग लंबाई लंबी 1 ईयर से चल रहा है, वो भी एक मेरा बाकी आपको
इसमें कोई प्रीडिस्पोजिंग फैक्टर भी मिला इसमें? सर इसमें बेसिकली हमारे दो उसमें एक तो उसके हेपेटाइटिस सी पॉजिटिव स्टेटस है। Secondly, sir, he gives a history of being treated by local practitioners in Narowal. Matlab, there is no proper documentation, and as we all know, that the local practitioners in periphery are coax. So most likely he has been taking recurrent steroid injections. He has been given recurrent steroid injections, which was a predisposing factor. Yeah, that's fine. लेकिन क्योंकि स्टीरॉयड इंजेक्शन से भी पर्टिकुलरली वोकल कॉर्ड का फोकस हो जाना वो इतना रेलेवेंट नहीं है। Sir, we did not find focus any specific focus in this patient, but again, according to the articles and research which we have studied, in 50% of the patients they are immunocompetent, and there is no significant history present in those patients. क्योंकि इस पेशेंट में काफी सारे ऐसे फैक्टर्स थे, जैसे लंग्स उसके बिल्कुल क्लियर है, स्मोकर भी वो नहीं है। स्मोकर है सर, स्मोकर है यस, तो लेकिन लंग्स में कोई ऐसे जो उसकी वो नहीं थी। बड़ा अनयूजुअल केस है जिसके अंदर मेरा ख्याल वो आइडियल पे वाइटिश लुक है, उसके अंदर एक पॉसिबिलिटी फंगस की भी आ जाती है। क्योंकि मैंने देखा है कि आजकल अक्सर हमारे यहाँ थ्रोट के अंदर भी हमारे जनरल प्रैक्टिशनर फंगस को ला रहे हैं विदाउट एनी क्लिनिकल सपोर्ट, जो उसको रिस्पॉन्ड नहीं कर रहे ट्रीटमेंट को। तो हमारे यहाँ अक्सर जनरल प्रैक्टिशनर या शायद बाज ENT वाले लोग भी जो है वो उसमें फंगस का एलिमेंट पेशेंट के ज़हन में डाल देते हैं, फंगस हो गया फंगस। क्योंकि ये टर्म बड़ी वेग सी यूज हो रही है, जैसे कान के अंदर कोई भी चीज जो थोड़ी सी लंबा तांग करे उसमें भी पेशेंट के ज़हन में फंगस डाल दिया जाता है, क्योंकि ये एक नई चीज है जिससे पेशेंट जो है वो नेक्स्ट टाइम जब एग्जैक्टली तो ऐसी रीजन के अंदर वो देखना चाहिए। इसमें सिर्फ दो
कमेंट्स और देना चाहता हूँ। जैसे हिस्ट्री में डॉक्टर साहब ने एब्रीविएशन की बात की है, तो बैग मेडिकल कॉलेज में इस एग्जाम ले रहा था, तो स्टूडेंट्स एब्रीविएशन को डिस्क्रिप्शन में भी पेशेंट वाज यूएसओएच यूएचएस में था, फिर मुझे पूछना पड़ा यूएसओएच क्या बात है। तो ये चीजें जब कहीं इस तरह की प्रेजेंटेशन में ब्रीफ करने के लिए रखी जा सकती है, लेकिन डिस्क्रिप्शन जब आपने एग्जामिनर से बात करनी है तो उसको क्लियर और सेकंडली प्रेजेंटेशन में किसी लैब का रेफरेंस नहीं देना चाहिए। This was done in Shogat. This was done in the hospital. वो रेफरेंस नहीं देने
जी
चाहिए।
सर।
You should track in terms of the level को ये किस लेवल
Yes,
की
sir.
लैब की अगर आप प्रिसाइजली
Precisely.
आई नो
Yes, sir.
आई नो कि आप इसमें थोड़ी सी
Yes, sir.
बढ़ाना चाहते हैं, but you can add this one.
Yes,
This
sir.
was done by a lab which is quite authentic rather
Yes,
than
sir.
saying Shogat.
Okay, sir. Thank you. Yes, sir.
I would still advise कि इस पेशेंट को आप फॉलो अप पे रखें,
Yes, sir.
गुड फॉलो अप, क्योंकि ये भी हो सकता है कि वो अंडरलाइंग मैलिग्नेंसी हो,
Yes, sir.
और जो भी एरिया बिकॉज ऑफ एनी इडियोप्लास्टिक प्रोसेस से क्लोज होता है टिश्यू, वहां पे सुपर फंगल इन्फेक्शन वो पड़े हुए होते हैं। तो ये पॉसिबिलिटी शुड बी केप्ट इन माइंड।
Yes, sir.
That's
I think we have learned here is anybody who comes with an immunocompromised like diabetic,
Yes, sir.
tuberculosis, we should keep in mind. We cannot, we don't take cultures of every
Yes, sir.
every God because, but this is the thing we learned today.
Yes, sir.
Looking at this case, it was a wonderful presentation.
Thank you, sir.
And another thing I would keep in mind is that we should also keep in mind HIV.
Yes, sir.
Because I think even myself, today I was thinking like after your presentation and after looking into this, that we don't do HIV just for patients
sir.
nowadays. Everything is gone. It's there.
Yes, sir.
Wonderful presentation.
Thank you, sir.
Actually, perhaps I missed in the presentation, you didn't talk about LFTs.
Sir, I talked about hematological investigations. So basically, it covered all of them: CBC, LFTs, RFTs. They were all normal. Hep C positive, but his liver functions were not deranged. Yes, sir. So we are monitoring his LFTs every 10 days. We are repeating his LFTs. And when he came for this follow-up, which I shared the follow-up FODL video, we again had his LFTs done and we checked it. They are still within the normal confines. And if they get deranged, then we will adjust the dose accordingly.
Very good.
Yes, sir. Yes, yes.
You took the maximum biopsy.
Yes, yes.
There was the ulcerative
Yes, sir. There was a ulcerative bleed left behind. Yes, sir. Yes, sir. Sir, sir,
पीछे उसके ulcerative mass बड़ा हुआ।
अच्छा सॉरी, एक सवाल देंगे
yes, sir.
अस्पर्जिलोसिस तो था,
Yes, sir.
कोई नॉर्मल सेल्स भी नजर आए उनको उसके अंदर?
सर उन्होंने म्यूकोजा उसमें बस मेंशन किया है, म्यूकोजा सेल्स नहीं कोई मेंशन किए सर उन्होंने उसमें। मैं ये एपिथेलियम सर उन्होंने मेंशन किए बीच में। यस सर।
पोस्ट ग्रेजुएट्स के लिए दिस पॉइंट शुड बी केप्ट इन माइंड कि जब आप रॉन्ग कर रहे हैं पोस्ट ग्रेजुएट, मैंने कहा बेटा बताओ क्या हिस्टोपैथोलॉजी क्या है इसकी, वो बताने स्क्वेमस सरकार से जो रिपोर्ट है ना पूरी ऊपर से नीचे तक के सेल्स कौन से हैं, डिस्प्लास्टिक है, इन्वेरियंस के पूरा पढ़ना चाहिए, तो वहां से आपको क्लू मिलेगा कि व्हाट यू टॉकिंग अबाउट।
यस सर।
जी प्लीज।
यस सर।
And my comment is that we being ENT surgeons, out of my question, license of respiratory diploma, or we see the those and paramedical sciences, that's what I'm saying, we provide. But it's more important than that. And guys, whenever we see a whitish lesion, we suspect dysplasia and crisis more often than aspergillosis. This is the first case I've seen in my life. And I appreciate it would not be expected initially. So if I say that it is a that might as well. More important is to remember aspergillus goes cavity and then rocket become oxygen बहुत ज्यादा common है dead bacteria को बहुत ज्यादा common है than and airway and also as for virus in the lungs. Only thing that we have seen is the S hepatitis C positive. So single hepatitis C positive also conditions are immunocompromised as I see. So this is what we learn from it. If you have to see a whitish lesion, you can be lysis also. Thank you.
Thank you very much, sir. Yes, sir.
Just keep refluxing.
Yes, sir. Yes, sir. Thank you.
Another thing, sir. Nowadays, we are seeing too many problems. Can it be related to the injudicious use of antibiotics? As this patient had used the antibiotics for the last 8 months, multiple dosing, multiple treatments of antibiotics. Can antibiotics injudicious use of antibiotics? This can be a one factor. So just don't write antibiotic. Just try to diagnose them.
Thank you, sir.
So we have seen the whole OPD, every patient is having antibiotic.
Thank you, sir.
आप लोग भी सवाल पूछो दो भी जेल में आता है कहाँ मतलब
If there are no further questions, then thank you, everyone.
थैंक यू वेरी मच सब लोगों का बहुत बहुत शुक्रिया स्पेशली प्रोफेसर मंजूर साहब नजमुल हसैन साहब तारिक साहब खालिद साहब खुर्शीद साहब इज वेरी काइंड इन्होंने लास्टली हमारे बड़ा अच्छा एक सेशन कराया हमें बड़ी अप्रिसिएशन मिली लिरेंजियल सेशन प्रोफेसर मंजूर साहब थैंक यू वेरी मच एंड ऑल द रेजिडेंट और हमने रखा था कि जो सबसे पहले हमारी मीटिंग में आएगा और रेजिडेंट और जो भी फैकल्टी मेंबर तो अब दो प्रोफेसर इकट्ठे इंटर हुए हैं तो हमारे लिए फैसला करना बड़ा मुश्किल है मंजूर साहब और प्रोफेसर अब्दुल साहब और नहीं जो पहला स्टेप था जो वो प्रोफेसर मंजूर साहब का अंदर था सो और जो है रेजिडेंट मुनीब ये पहले आए ऐसे तो इनके लिए हमने स्पेशल प्राइज है सो थैंक यू वेरी मच आपका बहुत बहुत शुक्रिया तो अब नहीं उनके लिए हमने ये प्राइज रखा हुआ है कि जो भी ये हमारी इस मीटिंग में प्रेजेंटेशन दे रहे हैं उनको हम पुल अप कर रहे हैं और एंड पे हमने उनको 2 वर्कशॉप स्पॉन्सर करनी है जो हमारी राइनोकॉन में आएगी उसमें उसामा उसमें बुलाना जरा सो नहीं रिजवान प्राइज दे दें सो नो आई रिक्वेस्ट प्रोफेसर नजमुल हसैन साहब कि वो मंजूर साहब को पहले आने पे तो सर ने अपना रिकॉर्ड बरकरार रखा है सबसे पहले पहुंचने का
And I'm sure there's a message for all of you.
Dr. Maneeb.
एक फोटो के लिए जरा वेट करें।
लास्ट में एक फोटोग्राफ और उसके बाद टी इज रेडी एंड डाइनिंग हॉल। थैंक यू।
अमन भाई बस अब ये बंद है, आप पिक्चर्स ले लें।